Here's something the data shows that nobody else is talking about. 90% of patients who get referred to a spine surgeon are not surgical candidates. 9 out of 10. They sit through the consultation, they hear the same version of, your MRI doesn't look so bad, or surgery just isn't the right answer for you right now. They then go back home and back in the same pain and have no new plan. I'm Dr. Savir Rao, triple board certified in pain medicine, anesthesiology, and functional medicine, and have treated over 20,000 patients over 20 years. What I've watched happen over and over is patients following the same exact system the way it's designed. They do the PT, they do the injections, they get the referral for surgery, they wait 3 months to get in, they go to the appointment, and they get told, we can't help you yet. Come back when it's worse. This is not a failure of the surgeon. A good spine surgeon only operates on patients who genuinely need surgery. The problem is what happens before you reach that office. Because for many patients, there is a critical step between physical therapy and that surgical consultation. And when that step gets skipped, you can wait months for an appointment only to leave with the same pain and no new plan. So before you see the spine surgeon, there's one other kind of evaluation I want you to know about. Why so many spine surgery consults lead nowhere? Here's how the standard referral path works. Your back's been hurting for a long time. You've done physical therapy. Maybe you've had epidural steroid injections, but the pain keeps coming back. Your primary care doctor looks at your chart, runs out of options, and says, I think you need to see a spine surgeon. One referral. PCP to spine surgery. One hop. And here's the structural problem with that. Spine surgeons do surgery. That's what they trained for. That's what their practice is built around. And a genuinely good spine surgeon will only operate on the rare patient who truly needs it. When a surgeon looks at your imaging and says, I can't help you, they mean it. Your case does not meet the surgical threshold, and for 90% of patients who aren't surgical candidates, that's the right answer from a surgeon. But here's where patients get lost. They waited 3 months to get into that appointment. They ordered the MRI. They took the time off of work to go back and get the results. But they heard doesn't look that bad. And then they found themselves right back where they started. Same pain, same uncertainty, and now with the feeling that surgery is somehow off the table without anything to replace it. Patients at this stage don't know what they don't know. They've done everything right. They followed the referral. They were patient. They trusted the system. And the system ran them all the way to the end of the road and sent them back empty-handed. The reason this happens is structural. The primary care referral path skips a step. Specifically, it skips interventional pain and minimally invasive spine medicine, which is the specialty that sits between physical therapy and surgery. Most primary care doctors were trained to route back pain patients to a physical therapist, and if that doesn't work, spine surgery. But interventional pain medicine is a newer specialty. It's genuinely underutilized. And the data shows that most patients who end up in a spine surgeon's office could have had a much more useful conversation with an interventional pain specialist first. And many of them would have never needed that surgical consultation at all. If this is putting words to something you've been through, drop it in the comments. Tell me where you are in the process, how long you've been dealing with this, what you've tried, and what you've been told. I read every one, and you'll probably hear back from me. The specialty the referral path skips. Interventional pain and minimally invasive spine medicine is a subspecialty that has developed over the last 20 years. It sits exactly between physical therapy and surgery, and it barely exists in the referral pathways most primary care doctors follow. Hence why there's a problem. Medicine takes a long time to change. Primary care doctors were trained to route spine patients to physical therapists or surgeons. That's the established path. Interventional pain and minimally invasive spine medicine is newer. The procedures are newer. The evidence base is newer. Most primary care doctors who graduated more than 15 years ago were never trained to route patients here first because this category of intervention didn't look the way it does today. What an interventional spine specialist actually does is significantly different from your standard pain management practice. They're not putting you on an injection schedule or just prescribing you medications and seeing you back every few months. They're doing a real diagnostic workup, reviewing your imaging the way someone who does this all day reads it, mapping your symptoms pattern against specific anatomical findings, and identifying the exact structural driver of your pain. Then they treat the structure directly without opening you up. The treatments this specialty now offers are a long way from just injections that wear off every few months. The field is super exciting and expanding. Spinal cord stimulation, for example, interrupts the pain signals before it reaches your brain. Radiofrequency ablation, done with precise targeting, quiets the nerves firing the pain signals for a year or more. Minimally invasive spine procedures for spinal stenosis, which is the narrowing of the spinal canal that compresses your nerves. We can decompress the spine through a needle-sized incision with no rods, no screws, no general anesthetic, and same-day discharge. Intradiscal biologics address the disc itself at the tissue level, not just the inflammation around it. These are designed to treat the source, not just manage the signal. Most patients sitting in a spine surgeon's office have never had a consultation with this specialty. They went straight from injections to surgical evaluation. The middle was skipped entirely, and the middle is where most of them belonged. If you actually do need surgery, this step gets you there faster. Here's what the one-hop referral from primary care to spine surgeon never gives you. If your workup does show you're in the 8 to 10% who genuinely need surgery, an interventional pain specialist can get you in front of that right surgical colleague that week, not 3 months from now. Because we know these surgeons, we work with them regularly, and when we make that referral, we've already confirmed you're a real surgical candidate. You don't need to start all over. You move forward with a clear picture. That's what that referral path skips. The spine surgeon is the endpoint of a diagnostic process that never got started. And when you land at the endpoint before the middle of the process has happened, the surgeon can only tell you what they see, which is whether you meet the surgical bar. When you don't, they have nothing else to offer. That's the boundary of the specialty. Spine surgeons give good advice about surgery. A good one will tell you the truth about whether you're a candidate. The problem is the path that sends you to them before anyone has worked out which category you're in. The question of whether you're in the 8 to 10% that need surgery or the 90% that don't belongs in the middle of the referral chain with an interventional pain specialist, not at the end of it. What to do before you walk into that next appointment? Find out whether you've ever had a real diagnostic consultation with an interventional spine and pain specialist, not a pain management doctor doing injections and prescribing medications only, but specifically someone who does full diagnostic workups and minimally invasive procedures. If you haven't, that conversation should come before the surgical consult, not after. It changes what questions you walk in with. It changes what you're comparing. In a lot of cases, it changes the answer entirely. If your primary care doctor hasn't made that referral, ask for it. Tell them you'd like to see an interventional pain and spine specialist before moving forward with surgery. That's a completely reasonable request. A good primary care doctor will support it. If they're not sure who to send you to, ask specifically for a fellowship-trained interventional pain physician or someone who's board certified in pain medicine. That credential covers the training that includes the category of this work, not just a general pain management practice, managing injections and medications on a rotating schedule. A specialist who does full diagnostic workups and minimally invasive structural procedures as their core clinical focus. When you do get in front of an interventional spine specialist, here's what that visit actually looks like. They're not routing you through the next option on a standard ladder. They're doing a real diagnostic workup, reviewing your imaging with fresh eyes, mapping your symptom pattern against specific anatomical findings, and identifying whether a structural cause explains your presentation. If it does, they then tell you what the procedure addresses that structure, why it's the right tool, and what to expect from it. If it doesn't, they tell you that too, and where that means the investigation goes next. That visit has a diagnostic output that a standard pain management appointment often doesn't produce. You leave with the plan built around your specific anatomy, not the next step on a standard referral ladder. When you book that appointment, bring whatever imaging you've had, the actual discs if you can get them, not just the written reports. Bring a timeline of what you've tried in that sequence, for how long, and what each one did. And be specific about your pain pattern, where it starts, where it goes, what makes it better, what makes it worse, whether it changes depending on whether you're sitting, standing, or walking. An interventional spine specialist uses all of that information to build a clinical picture that maps to your specific anatomy. The more detailed you are with your history, the cleaner picture they're working from. The system routing you toward a spine surgeon's office isn't wrong. It's incomplete. There's a step that belongs in the middle, and if no one told you about it, that's a gap in how the system has been built. It's a gap in the referral path that you can close before committing to anything. The question that brought you to that surgeon's appointment is actually the second question you need to answer. The first one is whether anyone has worked up which category you're in at all. Once you know that, the rest of the decision gets a lot clearer. One more thing worth knowing. A consult with an interventional spine specialist doesn't lock you into anything. You're not committing to a procedure. You're getting the diagnostic workup that tells you which category you're in. If you're in the 90%, that doesn't need surgery, that workup tells you what options exist and which one applies to your anatomy. If you're in the 8 to 10% who does genuinely need surgery, the specialist will tell you that and get you to the right surgeon quickly. Not in 3 months, but usually that week. Not in 3 months, but usually that week, because we know those surgeons and have already confirmed you're a real surgical candidate. The information is what changes what happens next. And going into any appointment, surgical or otherwise, already knowing your workup results changes every question you bring into that room. If you want to go deeper on what happens when you do see an interventional pain specialist, what to ask, what the minimally invasive options actually involve, and what to watch out before you say yes to any procedure, watch this next. It's called Before You Have Spine Surgery. Watch this.